States and Universidad del Valle in Colombia. As part of their academic interchange, 3 students of the Masters in Public Health of the FIU explored the results of patient safety culture surveys in hospitals of Brazil, Chile, and Peru. Culture is an important component to strengthen patient safety and healthcare quality. It measures the values and perception of the staff related to how things are done and aligns with safety in hospitals. In this seminar, few students will present results and highlight the main gaps in patient safety dimensions compared with the United States, and also taking into account previous works in Colombia and Latin America in general. We have 3 speakers. They are students of the Masters in Public Health of FIU. First, we have Ruth Adams. She's finishing the Masters in Public Health at FIU with a concentration in health policy and management. Ruth finishing her bachelor degree in Roberts University. Her bachelor is in international community development. And also she works for American Corps as FEMA Corps volunteer, supporting disaster responses in various states within the United States. She also worked for the Florida Department of Health with duty working in several areas in relation with coordination and administration and contact tracer. And she plans to continue learning about the field of public health in this master's and explain us her experience. Okay, welcome, Ruth. The floor is yours.
Hello, everyone. I'm going to attempt to share my screen. And can everyone see my screen?
It's perfect.
Okay, I'll go ahead and get started. And so, as you stated, my name is Ruth. Adam, I am, like you said, in my final semester at FIU with my concentration in health policy and management. And so, I previously graduated from Oral Roberts University in Tulsa, Oklahoma, and did spend some time serving in FEMA Corps along with some, like you mentioned, various duties with the Department of Health here in Florida as their CRI coordinator, dealt with fit testing for N95 masks, and then also did some contact tracing with them. My placement within this practicum experience is ongoing in the sense that it started in February and it's currently still going on now. My role of the 3 presenters was about assessing patient safety within Chile. And so for my practicum, it was a joint collaboration effort between Florida International University, Universidad del Valle in Colombia, and of course the Ministry of Health within Colombia. The Ministry of Health oversees many components as the central supply of the National Health Service System, the Superintendent of Health, the National Health Fund, and the Institute of Public Health. And with that, due to prior regulation as of 2005 in regards to the DFL or Decree of Force law, the Ministry of Health has been empowered through the government to establish accreditation within the country, and then also the Superintendent of Health, they aid in the establishment and the regulation and maintaining of accreditation in the country. When it comes to background on Chile's healthcare system, it can go back quite a few years, but some highlighted key points that I wanted to note was the introduction of the National Health Insurance back in 1924. Basically, this fully funded by the government. The next key point was in 1938, where the Preventative Medicine Act, with this, it targeted detection and treatment of cancer, heart disease, TB, and syphilis within the country's population. In 1952, Chile's National Health Service, or NHS, came to be. It was mentioned in my research that it was possibly modeled after the 1948 NHS in the UK. And it basically provided blue-collar workers and their dependents medical, dental, cash, sickness, and healthcare benefits. Sermina came about around 1968, and this aided with the help of national insurance and national medical coverages. Going down the list, 1979, FLANASA came about, ISAPRE in 1981, PROMAP in 1992, the Explicit Guarantee System around 2005, and PEPSIS in 2008. And some of these programs range from targeting blue collar or white collar workers, or even the indigenous populations within Chile at the time. So for this practicum, we were trying to address the public health problem. And so some of what was coming about were each year, approximately 134 million adverse health events occur in hospitals in low and middle income countries due to unsafe care, resulting in 2.6 million deaths, according to the World Health Organization. They also estimate that approximately 80% of that harm is preventable. Patient safety culture, according to research, is deemed to be an unknown and unmeasured concept in most Latin American countries. Surveys conducted within the Ministry of Health for Chile did also note the need for patient safety specific laws, as they don't exist specifically by that title within the country at this time. And then just to summarize it, it's not just the fact that there are errors or increasing frequency of incident where patients' safety or harm is taking place. It's also the fact that there are not sustainable significant measures in place to address and reduce repetitive events from occurring where harm is taking place towards patients.
Ruth, are you still there? Ruth, we have a problem with Ruth. Let's see. We lost her connection. Please wait a second.
Hi, Andres. I will check if she reconnects.
Yeah, she's there, but something is wrong with her signal.
Yeah, she got disconnected, so I guess she will re-enter.
Okay.
Yeah, let's wait 1 or 2 minutes and let me check. Yeah, Ruth is there. Hello, Ruth. Are you there? Okay, she's going to leave and connect again.
Hello, everyone. Sorry about with the connection.
Don't worry, Ruth. Yeah, you are here again. Thank you.
I will do my best to attempt to share my screen one more time.
You can continue. Perfect.
Okay, it's showing.
You were explaining the history of the Chilean health system. Thanks.
Yes. Okay. Let me go back to. Okay, and so I'm not sure if it came across or if it broke up at the time, but I just provided some information on why this practicum, why the need was there to assess patient safety in Chile, just regarding the extensive cases that have been compiling through the years, where there's been adverse events in hospitals, and the lack within the country, not just by outside entities, but even through surveys conducted with the Ministry of Health, the need for patient safety specific laws within the country. And so, as I was trying to say previously, it's not just about the existence of errors regarding harm to patients, it's also the lack of significant sustainable measures in place to address and reduce those repetitive events of harm from occurring or that patients are experiencing. So within the HMA surveys that were conducted, they were assessing hospitals in the USA, as you can see is represented in the blue, and they were also assessing private hospitals in Chile in the green and public hospitals as denoted in the yellow. And so some of the main components that was taken from that data included the fact that there were gaps within these composite measures. And so as you see on the side, there are 10 composite measures that all three categories of hospitals were assessed by. And so when it came to Chile versus the US, the gaps that were about 10% or more were occurring in communication about errors, hospital management for patient safety, response to errors, and staffing and work pace. Now, the largest gap of the 10% would be between communication about errors, hospital management, and support for patient safety response and staffing within the workplace and work pace. So something to consider as I was diving into the data, within each composite measure, they had units to kind of pinpoint what these problem areas could be when assessing patient safety. And so within unit 2, it was showing that some of the private hospitals were behind the public hospitals by about 4% when it came to improving patient safety. And something that could be considered as a factor in that may be the fact that the private hospitals are perceived to be better centers of care, and they themselves might not be challenging themselves. It may also be factors that include they're within their own network. So there's no necessarily a universal standard of care that they're maintaining. They have their own internal standards. Another factor to keep in mind may be the atmosphere, where they're not necessarily being set with goals to continuously improve and work on improving patient safety. Another unit also talked about Unit 3, hospitals letting patient safety problems continue happening. And that was noted to be at 71% or higher, which would be for the public hospitals. And that could be, preluding to the problems of, could be simply cultural ideologies of how patient safety approaches should be done. It could be timely access to resources, may vary by regions where the hospitals are located, whether more remote or more centralized locations. Lack of funding is also another factor to consider, as it can be an impediment for hospitals when it comes to staffing, training, resources, and implementing corrective actions. Another factor would be the private versus the public hospitals in Chile. And so within that arena, two of the more, the larger gaps were within organizational learning, continuous improvement, and hospital management support of patient safety. And so within that area, it denotes patient safety falls not only on the individual, but on the institution as well. And so it brings to mind the fact that the Ministry of Health and those larger entities within patient safety, within healthcare administration and management, may need to assist more in the sense of creating an atmosphere where they are able to remove blame on the individual level, make corrective actions, and also maybe possibly putting in place mandates where everyone is required to comply. Another factor in Unit 4, as seen there, is the fact that response to errors. And so something that was coming up in the data that I was going through was the lack of support for staff involved in patient safety errors. And so sometimes it becomes a factor where they feel like they're being blamed, or the fact that it may lead to negative repercussions on them as staff. And so some cases may result in patient safety incidents being underreported for fear of retaliation, or it may just be the need for further training or assessment, but not just on an individual level, as a unit or as a staffing, to just ensure that these incidents don't progress and are not just handled on an individual level. And so some recommendations that came up as I was going through the practicum information and the assessment, I broke it down into 3 primary areas, which would be partnerships, people, and policy. And so it does support the data within the survey to increase partnerships on all levels. And so when we're talking about strategic partnerships, there are direct channels like the Ministry of Health or hospital administration or board of directors if it's a private healthcare entity, that can be resources or channels for people to get faster connection to what is needed to better treat patients. However, it is important to also consider non-traditional partnerships, think outside of the medical arena, where you can make partnerships with possibly logistics company or transport entities, things that you may not initially think of when you're thinking public health or healthcare, but they can aid in cost reduction and still facilitating those higher needs for patient safety as the health entity pursues those goals. Another step that I noted in my research was people. It's difficult sometimes when you have existing staff and they've been through hardships within the job to change those opinions, to change those perspectives. And so I believe that's an area that, although it's difficult, and I'm sure some of you may have experienced changes on the job and the adjustment there, having staff buy in on new ideologies or having staff want to participate in shifts of goals and restructuring is a key component to successfully implementing patient safety standards. And so it's also important that when you're serving the people of various communities, that you consult the representatives from those communities. You don't want to come in and just kind of lay down the law of what you think is what their needs are, or what you think is the best way to achieve those needs or goals. It's important to also hear from them, processes that they think would work, not only staffing and hospital administration wise, but if you're dealing in an indigenous community or you're dealing in a remote location, these people have valuable insights, whether it's their community leaders or just patients or well-known people in the neighborhood. They have valuable insight that can also be considered when making patient safety recommendation. And then last but not least, another recommendation is definitely within policy. And so when talking about policy, like previously stated, healthcare laws within Chile has come a long way, dating back to 1924. And yet today there's still room for growth in the sense of having those laws created that specifically target patient safety within Chile. And so an example could be within the United States. There was the Patient Safety and Quality Improvement Act of 2005. This act, kind of similar to what I was mentioning before, it entailed partnerships where the Secretary of the Department of Health and Human Services here in our country consulted with the Director of AHRQ to prepare a report of effective strategies for reducing medical errors and increasing patient safety. Now, that was more on a national level. However, even within the state of Florida, there came about the Florida Statutes 395.1012 on patient safety. And within this statute on a state level discussed the importance of patient safety, having healthcare facilities become mandated, create patient safety plans, appoint patient advocates, share their internal information regarding incidents or errors within a hospital-acquired infection, and also 15-day readmission rates. And all of these were components that were necessary and helpful in not only addressing patient safety, but things that Chile can pull from when going forward to create their regulation and their healthcare laws. And I just wanted to say thank you to my professors and practicum coordinators for the opportunity to work alongside this multidisciplinary and international team in assessing patient safety. So that's the end of my presentation. Thank you all so much.
Okay, thank you, Ruth, for your presentations, and we know that you have to leave, and I have some questions here, and extra, and maybe the public also, they have some questions. My question is in relation with response to errors and also communication about errors. Do you have some extra suggestions for the work in Chile? Because it seems they have problems with the communication errors and response to errors among staffs and management.
Yeah, so I think one example that would be a good management tool when it comes to communicating errors is just improving as a whole their health information systems, like the management of patient information, better tracking of how a patient goes from one doctor to another, or if they were at a private hospital and they decided to go to a public entity, having a more centralized system of where that health information is kept and shared. It prevents some of those misunderstandings when the patient shows up to you today and you have no idea of their history beyond what they're able to communicate to you in the moment, you know? And so if they're having an immediate need, you're only able to go off of what they're telling you their current symptoms are or what they choose to share with you in that moment. However, if the health information is being shared through an interconnected network, that helps to alleviate some of those maybe delayed responses that isn't necessarily the physician that's currently tending to the patient's fault, but they would just get a more clear picture of what's that patient's true medical history is. And then that also now helps that when an error does occur, they can trace back of like, where did this medication get introduced to the patient? You know, why was this symptom, oh, it was reported here or it wasn't reported here. And so some of these things, it's not necessarily for blame, but just a better timeline of what's going on within that specific individual's history.
Okay, thank you. Maybe the public have some question from the public. It could be in Spanish also, and we can translate. Alejandro, do you have any comment, an extra comment before pass to the next student?
Hi, Andres. Thank you. Yes, I have a quick comment. Ruth, I liked your presentation. Thanks for presenting the results and provide some recommendations. So one of the points is that the Chile sector, right, the health system in Chile, you mentioned that they have some regulations, etc. And I know they are trying to change patient safety, to improve patient safety. They found that accreditation becomes kind of a checklist sometimes that really doesn't change the system at all or completely, and they're now thinking about how to incorporate this type of surveys, right, to assess what happened at the cultural level in the organization, right, and how that these surveys can inform the regulators or even the hospitals to do deeper changes, right, in the organizations, in the hospitals. So you mentioned the case of Florida, where they have a regulation where they make it mandatory to have the patient safety culture survey. What is do you think these surveys will, if they are become mandatory as part of the regulation in hospitals, do you think that they will really improve patient safety, or you feel that other type of conditions are needed?
So I believe, thank you for your question, Dr. Arrieta. I believe that they are a integral step toward patient safety, because what was considered safe for patients 30 years ago is by no means necessarily the same standards we have today. And so patient safety is something that'll be consistently evolving as the needs of the communities being served change. So with that in mind, it's a good step by first off creating it as a mandate, because now it's required whether you have a board of directors or you don't, or you're in a rural community or you're not. Just creating this baseline of what is expected as a patient's rights when they go in to be, tended to, or when they come in with the healthcare complaint and they're seeing a physician. that baseline is the bare minimum of what their experience should be. And it's not something that you can only say with, like you said, you don't want the patient safety surveys to become a checklist. It does require staff and frontline worker buy-in. And that's difficult, like I mentioned, because if some people have been at an entity for 20, 30 years, they've been through a lot of changes within healthcare organizations. And so sometimes changing their perception of what's right and what's acceptable and what they think is the best is difficult. However, I think it's an all hands on deck thing. And so if everyone is contributing as requirements for patients change, I believe approaches will change. And so the law isn't the goal, but I feel like the law is more of the a law mandating patient safety surveys or any laws in patient safety isn't the like pinnacle of what we're seeking. I think it's just creating a platform for whatever patient safety needs may be in the future.
Okay, thank you. Thank you to Ruth for your great presentation about the situation in Chile. Do we have any other question from the public? Okay, I think that it's okay, and we can, thank you very much. And now we can continue with Jaylyn.
Hi, yes. Let me share my screen.
Yeah, I will do a short introduction to Jaylyn because I have seen that you have a formal introduction in your slides, but also Jaylyn is finishing the Master's in Public Health at FU, and she graduated from Florida Atlantic University with a Bachelor in Health Administration degree. Okay, and welcome Jaylyn to this academic activity. Thank you.
Thank you. So yes, my name is Jaylyn. I'm finishing up my Master's of Public Health in Health Policy and Management at Florida International University. And I did my research on Peru, and I assessed their patient safety culture there. So I will be going over that. And of course, the site was at Universidad del Valle in Cali, Colombia, in collaboration with Florida International University. And then a little bit about patient safety and its importance. So the importance of patient safety is increasing, driven by a lot of epidemiological research revealing the degree of unsafe care. The Latin American study of adverse events found that 10.5% of patients from Argentina, Colombia, Costa Rica, Mexico, and Peru experienced a medical error, mostly related to hospital-acquired infections, surgical procedures, patient management, and nursing care. This study indicates that 1.8% of patients die because of those errors, and experts estimate that as many as 98,000 people die in any given year from medical errors that do occur in hospitals. So it is super important that hospitals do keep track of patient safety in their organization. And then a little bit about Peru's healthcare system. So the Peruvian healthcare system is comprised of 5 core decentralized entities, 4 public and 1 private, each with its own separate facilities. So first, they have the Ministry of Health's health insurance program. This is the largest insurance provider, covering about 60% of the population. Second, the Ministry of Labor, Social Security, Salud, which I'll talk about, which covers those in the formal economy, or about 25% of the population. And then the remaining 10% of the population, which receive services from the armed forces, national police, and the private sector. And then I found while doing my research that one of the most important challenges facing the healthcare system there, which also presents a major bottleneck in their movement towards universal coverage, is the continued shortage of doctors and medical specialists. So I kept this in mind when I got the results back. So survey implementation. So an online survey was administered to clinical and non-clinical staff working in Latin American countries from March to April 2023. This is a non-random cross-sectional study conducted online. It's a modified version of the hospital survey on patient safety culture, the second version, and it uses 32 questions to assess the 10 dimensions of patient safety culture. Respondents were also asked 6 demographic questions and 2 single item measures. This was how many patient safety events have they reported, and to provide an overall rating on patient safety in their unit or area of work. These were the 10 dimensions of patient safety culture. So the first one was communication about error. Second, communication about openness. Third, handoffs and information exchange. Fourth, hospital management support for patient safety. Fifth, organizational learning, so continuous improvement. Six, reporting patient safety events. 7, response to errors. 8, staffing and workplace. 9, supervisor, manager, clinical leader support for patient safety. And 10, teamwork. So 40 hospitals, a part of Peru's Salud system, received the survey. 41,465 surveys were sent out. There were 12,007 respondents for a 29% response rate. And then I did look mainly at ICUs, and there were 800 respondents in the Salud system that did respond. So some of the titles of those surveys, so nurses, there was 6,391, so 53%, so most respondents were nurses. Doctors, 1,935, 16% surveyed. Those in other clinical positions, 1,619, so 13%. Those in non-clinical support positions, 1,469, so 12%. And then management positions with the least percentage at 593. So some main results when I got the survey back, that I saw that the Salud system's ICUs actually scored higher in every single category of the survey than Salud non-ICU units, which I wasn't really expecting. I work in ICU units now, and usually there's more error in ICU units than non-ICU units that I see. And then the Salud system, United States, and even non-Salud Peruvian hospitals all scored highest in the teamwork category, which I thought was interesting. And then compared to 19 Peruvian hospitals not a part of the Salud system, Salud scored lower in patient safety scores. And then compared to the United States, 2021 results, the United States scored relatively higher in all patient safety components than Peruvian hospitals, especially in the Salud system. And then a little bit of a deep dive into ICU versus non-ICU units. I looked at the lowest scoring categories, and the lowest scoring categories for ICU units were staff and pace of work and response to errors. And then I deep dive into the components in that to see what was the least, the worst scoring, I would say, item category. And I found that it was the staff in this unit works longer hours and is best for patient care with a 29% positive response rate. And then for response to errors, the lowest scoring item level in that category was when an incident is reported in this unit, it feels like the person is being reported and not the problem. And then when I was looking at the lowest scoring for non-ICU units in the Salud system, it was the same two that had the lowest scoring categories, which was staff and pace of work and response to error. So when I took a deep dive to see which was the lowest scoring category within that component, for staff and pace of work, it was the staff in this unit work longer hours and is best for patient care. And then in this unit, there's a lack of support for staff involved in patient safety errors for the category of response to errors. Also for physician patient safety ratings, I looked into this for the Salud hospital system. Looking at all units, 18% rated their unit excellent or very good. In the Salud hospital system, just focusing on ICU units, 20% rated their unit excellent or good. And then in the non-Salud hospitals of Peru, 35% rated their unit excellent or good. And I compared that with the United States, where 64% rated their unit excellent or very good. So the Peruvian hospitals had lower ratings, a lot lower ratings than the United States on patient safety ratings. So my recommendations were that the Salud does need improvement on the hospital's response to errors and staff and pace of work for both ICU and non-ICU units. And they can do this by maybe getting more support from management when staff are reporting errors and decreasing hours work and workload to best serve patients. Another recommendation was to include physicians in patient safety trainings, because there are not a lot of physicians that are included in that right now. Also increased funding to additional units to departments, as resources and funding did increase for ICU units after COVID. This might be why ICU units had higher ratings on patient safety than non-ICU units. And then lastly, I put that more research on patient safety culture should be done in Peru. While I was doing my literature review, I didn't find a lot of research on patient safety culture in Peru. So that is something I do recommend. And then these are my references that I used during my project. And that is all for me.
Okay, thank you, Jaylyn, for your presentation. It's a clear presentation about the situation in Peru. And I have some questions, and after that, some questions from the public, maybe. For me, it's interesting to see the different ratings in relation to patient safety in ICUs and in other places of the healthcare. And what is your recommendation in relation with the pace of work? Because it seems that pace of work in the intensive care units is a problem reported in Peru in relation with patient safety. How can Peruvian physicians can improve the situation in ICUs? Thanks.
So when it comes to maybe the way I look at it is everything kind of starts from leadership and management, and making and creating a safe area for staff to be able to report problems for that whatever's happening in their unit and to feel safe doing so. I also think when it comes to physicians, it's just really including them in on patient safety and the trainings. I feel like that's more something that nurses are a part of rather than physicians. Of course, nurses are with the patients 24/7. There's always a nurse there, where physicians are all over and they might have 10 patients that they have to, think of. So just including them and creating an environment. I also am a big advocate of patient safety rounds, doing those in hospitals. So, it's not only dependent on one person to speak up or report an error. Everybody's involved, from nurses, physician, maybe quality, whoever the hospital wants a part of the patient safety rounds. And then for pace and workload, that's hard. Obviously, I don't work in the hospitals. I'm not in the hospital system in Peru. But maybe, developing trainings or programs so there can be more openings for people to get involved in healthcare and being a nurse or a doctor, things like that.
Okay, thank you. Alejandro, do you have a question? Comments?
Yes, Andres. So, Jaylyn, yeah, you focus on the ICUs. I remember in our discussions, we find out, you present that today, right? That usually ICUs are, have a more negative perceptions from the part of staff. But then apparently, probably it's after COVID when the government put more resources, right, to ICUs, and then a new generation also of physicians are taking the leads now of these units. So, ICUs become the most important units during COVID. So probably that change has affected, and as you said, now things are similar. But do you think those changes are sustainable? Because ICUs are very challenging, right? They have more patients. They have a lot of constraints, and so I just wondering how sustainable will be this. And what do you think are the key components that can, lead this to go back to the old time, right, where ICUs were problematic?
Yeah, I do think after COVID, a lot has changed, across the whole world in regards to how hospitals run their ICUs and care for their patients, which I do think has helped us in a lot of ways, but also hindered us in a lot of ways as well. But when it comes to making this more sustainable, I would say it's really up to the leadership and putting leadership in the hospital system that really cares about the patient safety and and cares about making this sustainable. You know, we could have another pandemic or something happen and the same thing happen with COVID again. But it's keeping procedures and policies in place that probably happened after COVID and Peru and the United States and all over to really make sure that it stays consistent and sustainable for the years to come.
Thanks.
Okay, thank you. And from the public, is some comment or questions in relation with Peru and patient safety? Also in Spanish, we can translate. Okay, thank you for your great presentation, Jaylyn, and we can continue with Derek. I don't know if Derek is already here with us.
Yeah, Andres, Derek won't make it. He emailed me. He had some issues. I mean, he had a lot of issues with his family recently. So apparently he won't be able to join today. So we only have these two presentations, Peru and Chile. So Derek was supposed to present in Brazil, something similar, but he won't make it today. So
okay, but I would like to, I don't know, with you and me, we can summarize something in Spanish for some of our public that have been, for having a general idea about this surveys
right.
in several countries. I think this is important to explain. Maybe we can explain in Spanish to the public the methodology of surveys in general and what was the main purpose and objectives of surveys in different countries, as we have seen today into the presentation from Chile and Peru, and maybe we can discuss a little bit 5 minutes in relation with this kind of surveys in Spanish. I think part of our public could understand
right.
the general ideas behind the surveys. Okay,
Yeah.
let's pass to Spanish. Jaylyn and Ruth can stay with us to listen a little bit of Spanish with us. Thank you.
Perfecto. Andrés, es una excelente idea. Yo quiero comentarte que esta encuesta que hemos hecho, y de hecho lo hemos hecho en colaboración también con la Universidad del Valle en Colombia, a varios hospitales de Colombia. No se han presentado los resultados de Colombia. Las hemos hecho también en Chile, en Perú y en Brasil. Son unas encuestas que miden la cultura de seguridad del paciente desde la perspectiva del personal de salud. Y es una encuesta que se basa en una encuesta que se aplica en Estados Unidos y que se aplica realmente en varios países. Es una encuesta que ha sido traducida a muchos idiomas y se ha aplicado principalmente a países desarrollados, digamos. Y este esfuerzo que hemos hecho, digamos, a nivel multipaíses y multihospitales es realmente único. Por lo menos en la experiencia que nosotros tenemos, no se ha hecho la misma encuesta, el mismo instrumento en varios hospitales de diferentes países de una misma región. Y el objetivo es aprender en forma conjunta, ¿cierto? Nosotros medimos la cultura, pero finalmente la cultura de una organización, en este caso de un hospital, está obviamente afectada, influenciada por la cultura del país y por la cultura de nuestras regiones. Nosotros tenemos muchas cosas en común como países, entre Colombia, entre Perú, Chile, y eso definitivamente uno lo percibe cuando ve los resultados de la encuesta, ¿no? Hay puntos en común que se repiten en varios países, por ejemplo, este tema de la cultura punitiva, ¿cierto? De pensar que si uno reporta un error, lo van a tildar, ¿cierto? Lo van a acusar y finalmente en vez de hacer un bien, uno termina perjudicado. Esa cultura de reporte y, bueno, Jaylyn también lo mencionaba, Ruth también, el liderazgo, ¿cierto? Un compromiso real. Entonces hay una serie de componentes que se repiten entre países y un poco el objetivo de la encuesta era ver esas cosas en común, tener un aprendizaje a nivel de sistema y eventualmente el siguiente paso es qué políticas se pueden recomendar. Una de estas era, ¿por qué no hacer estas encuestas obligatorias o por lo menos recomendadas como parte del proceso de acreditación para ver cambios, digamos, más de fondo? Obviamente la encuesta en sí sola mide, cosa que es importante para detectar las brechas y los problemas, pero no es, falta el siguiente paso, que es, bueno, ¿qué acciones tomamos, cierto? Pero, digamos, por algo se empieza, y creo que eso es un poco el objetivo de la encuesta y de los trabajos que hemos hecho.
Sí, muy bien. ¿Y cómo vieron la respuesta en diferentes países? Porque entonces hay diferentes prácticas pues, locales en Chile, en Perú, en Colombia. ¿Cómo vieron que se comportaba la encuesta en estos diferentes escenarios y también en prácticas públicas y privadas?
Mira, hay una percepción, empezamos por lo público y privado. Hay una percepción obvia, ¿cierto?, de que el privado va a estar mejor que el público. Y eso es cierto en algunos países. En Perú es claro. En Chile no. En Chile la verdad es que no hay mucha diferencia entre el público y privado. Entonces, en Perú, donde hay pocos recursos, se manifiesta, digamos, esas deficiencias. En Colombia no lo hemos podido ver porque no hemos tenido, digamos, acceso a muchos hospitales públicos como para poder comparar. Pero, digamos, allí tienes dos países donde hay una brecha entre el público y privado, como Perú, donde hay una clara falta de recursos, pero no tanto en el sector, en Chile. Y en términos de países, nosotros hemos hecho esta encuesta antes, con otra versión, también en Chile, Perú, Colombia, y hemos vuelto a encontrar lo mismo. Chile es el país que, digamos, ha hecho más avances, ¿ok? Pero muy cercano, y yo diría casi empate, está Colombia, ¿no? Colombia en los resultados de la encuesta está muy parecido a Chile, un poco por debajo de Estados Unidos todavía en algunas áreas. Pero en términos de voluntad de hacerlo, es mucho más marcado en Chile. En Chile hay un deseo incluso del sector público de implementar la encuesta, de cambiarlo, ¿no? De la cultura, de medir la cultura. En Colombia son más aislados, digamos, iniciativas de algunos hospitales, mayormente privados, pero no de una manera organizada. Y Perú siempre ha estado por debajo. En Perú realmente hay muchísimo trabajo por hacer en términos de seguridad del paciente, y eso se ve en la encuesta también, desde la participación, que siempre ha sido muy limitada, y obviamente los resultados que siempre han estado muy por debajo de Chile y de Colombia, ¿no?
Muy bien, muchas gracias. No sé si nuestro público hispanohablante tiene preguntas para el profesor Alejandro sobre esta encuesta de la seguridad del paciente.
Andrés, ¿may I talk?
Sí, escucho, gracias. ¿Quién es? ¿Ana Fernanda?
Sí, señor.
Listo, perfecto.
Bueno, no sé si en español o en inglés, Alejandro. Quisiera saber, en Colombia, en el sistema obligatorio de garantía de calidad hay 4 componentes. 3 de ellos son obligatorios. El primero, que es el sistema de habilitación. En el quinto estándar, que son los procesos prioritarios, está la política y seguridad del paciente. Entonces, tanto consultorios como hospitales, los 4 tipos de prestadores, que es el profesional independiente, la IPS, el objeto social diferente, que son las universidades que brindan capacitación al personal de salud que tienen clínicas, y las ambulancias, es obligatorio que se tenga. Por ende, parte no es solamente tener un documento escrito, sino que se debe implementar y se verifica en habilitación, que es una norma que todos deben de cumplir. Ya el que está acreditado, y uno ve, por ejemplo, aquí en Cali, 2 instituciones grandes en las cuales inclusive hay seminarios y hay cuestiones como son Imbanaco y Valle del Lili, que participan, que muestran uno tras otro cómo han ido poco a poco mejorando ese reporte, porque es una cultura que va desde el vigilante hasta el gerente, pasando por todos los diferentes cargos, no solo administrativos, sino clínicos. Entonces la pregunta va, ¿en los otros países tienen también esta norma de que se debe implementar la política de seguridad del paciente en lo básico que es habilitación, o no existe eso?
No, sí existen políticas en Chile, en Perú, en el mismo Brasil, existen. En todos los procesos, en la habilitación, por ejemplo, sí pueden haber diferencias. Algunos no son tan, digamos, tan explícitos en la parte de seguridad del paciente o calidad, pero sí lo hacen en la parte de acreditación. ¿Okay? Algunos digamos, lo hacen en el equivalente a habilitación, y otros lo hacen en la parte de acreditación. Y todos los países ya tienen algún tipo de acreditación, similar a Colombia, que es voluntaria, digamos, ¿no? En Chile lo están tratando de hacer más obligatoria, pero sigue siendo, digamos, principalmente voluntaria, y hay un pequeño grupo de hospitales que tienen el proceso de acreditación. Pero te puedo contar el caso de Chile. Creo que es la discusión principal. Uno puede tenerlo en la norma, ¿cierto? Uno puede tener en la norma, ya sea de habilitación o de acreditación, que se cumplan con estándares, con procesos, pero finalmente terminan quedando en el papel en muchos casos. Tú mencionabas el caso de Imbanaco y de otros hospitales que son, pues, hospitales bandera muy reconocidos, pero usualmente son el trabajo de una persona o de un equipo. No es la mayoría, no se generaliza. Y eso lo ves en algunos hospitales, ¿no? Hay un líder en calidad, o un director médico, o un gerente que realmente está muy comprometido con el tema de seguridad y hace cambios muy grandes. Pero cuando uno quiere llevar esa fórmula a otros hospitales, se queda allí un poco sin el piso, digamos, ¿no? Entonces, el papel ayuda mucho, sin duda, y eso yo creo que ha ayudado mucho a Colombia y a Chile. Les da como un piso un poco más alto, pero no garantiza que esto sea sostenible, que, como decías tú, lo vea desde el personal de limpieza hasta el cirujano más especializado, ¿cierto? Realmente, para que llegues a ese nivel se necesita un cambio en cultura. Y es un poco eso, la gran pregunta que tenía Chile, por ejemplo. Nosotros hablamos con el Ministerio de Chile y ellos decían, la acreditación se ha quedado en un checklist. De hecho, en Chile ya hay consultores, hay muchos consultores, les llegan al gobierno, digamos, los paquetes de acreditación que son iguales entre hospitales. Uno lo revisan y dice, pues no hay mucha diferencia entre uno y otro, porque finalmente contratan a un consultor que les hace todo el proceso de acreditación para pasar con los checklists todo lo que todo lo que pide la norma. Pero no hay un cambio realmente en toda la organización, ¿cierto? Que vaya, como decías tú, desde de limpieza hasta el personal más especializado. Y esa es digamos, la gran preocupación de Chile. Un ejemplo análogo es, por ejemplo, el inglés, ¿no? Yo siempre lo pongo como un ejemplo. Tú sabes, para acreditar que sabes inglés hay unos exámenes, ¿no? Como el TOEFL, por ejemplo, es un examen de inglés que acredita que sabes inglés. Pero en Estados Unidos, por ejemplo, por muchos años, los estudiantes de la China tenían el puntaje más alto en los TOEFLs. Pero cuando llegaban a Estados Unidos no se les entendía, pero nada, ¿cierto? Entonces, eso haces el checklist, te aprendes las cosas, pues vas, lo que te pide la norma, pero no hay garantía de que realmente domines el idioma, o que hagas las cosas bien en seguridad del paciente. Entonces, hay esta idea de cómo medir y cómo usar estas encuestas para mejorar, ¿cierto? La cultura en general.
Y el trasfondo entonces de aplicación de estas surveys, pues, o encuestas, es proponer cómo se puede implementar y mejorar la cultura de seguridad del paciente, o cuál es el trasfondo de hacerlas. Porque realmente, pues les digo, o sea, de lo que yo he ejercido, yo soy odontóloga, administradora en salud, auditora en salud, he ejercido por mucho tiempo, tanto en EPS como ya asesora externa. De la universidad también tengo un magíster en salud pública, estoy terminando un doctorado en educación. Y realmente para uno hacer ese cambio, tiene que empezar, o lo percibo yo en las asesorías que doy, uno es el querer desde del gerente, del que esté dirigiendo la IPS, porque ese es el que empodera y luego ya de ahí para abajo es sembrar esa cultura y el poder decirles cómo les gustaría que a ellos mismos los atendiera, que no hubieran fallas, no porque los están viendo, porque en una auditoría in situ uno se puede parar por ver nada más cómo están haciéndolo, no pedir el papel nomás, sino ir a ver cómo lo están haciendo. Y ahí es donde uno detecta las fallas. Entonces, en realidad uno quiere, es como cambiar ese chip que tiene la gente, que no es porque otro le esté diciendo cómo hacerlo, sino por su propio beneficio y por de no tener, por ejemplo, eventos adversos o demandas, pero a su vez es por el bien del paciente. Y uno ve como también algunas clínicas llaman ya después de una cirugía o un procedimiento, cómo le fue, qué tal fue. Otras mandan una encuesta al email del paciente, pero hay otras que son tan sencillas como son los buzones de sugerencias, que si se tuvieran los ítems, los puntos de verdad en cada uno, ahí es fácil detectar, porque a mucha gente le da pereza ponerse a escribir, pero cuando a alguien le va bien mal, entonces él coge ese buzón y es algo cortico, pero ahí pueden detectarse las fallas. Y si se implementa una cultura de estar revisando esos buzones, es como una alarma, de poder por cada uno de los servicios poder ir viendo cómo se mejora. Porque, o sea, por más de que estén acreditados, hay fallas. Y ellos dicen, no, es que ya no son 100, son hasta 1000 reportes, inclusive de eventos adversos. Pero pues no debería de ser así. Antes, si se detecta algo, cómo se ha ido bajando a través del tiempo, ¿no? Entonces la pregunta va es, ¿qué quieren porque qué pena, ingresé muy tarde, estaba lejos, no puedo entrar por el teléfono. Entonces quisiera saber el trasfondo de estos surveys en todos estos países, porque me llama mucho la atención este tema. ¿Qué quieren? ¿Qué es lo que quieren lograr?
Claro, mira, realmente esta es una iniciativa de varios países también. De hecho, la OSD, la OCDE, ¿cierto? También está recopilando información de este lado, del lado del personal. Lo que tú has mencionado de los buzones, ¿cierto? Y las quejas de los pacientes, es del otro lado del paciente. Muchas veces, como bien dices, solo uno recibe la información ya de cosas muy graves, ¿cierto? Y es valioso tener ese lado, el lado del paciente, pero también es valioso tener el lado de lo que está detrás de la cortina, ¿cierto? Y ese es el personal realmente, y todo el personal. Esta es una encuesta que llega a todo el personal, desde limpieza hasta nuevamente al cirujano más especializado. Y entonces, esta es cómo uno percibe cómo recibe o mide estas percepciones del personal sobre la seguridad del paciente en la organización. Entonces, yo digo, 3 principios, digamos, claves, ¿ok? En esta encuesta. Primero, que como es una encuesta para todo el personal, esta es una oportunidad para que todo el personal vea el interés de la organización digamos, en saber, en escuchar, ¿cierto? A todos sobre qué están pensando o qué han observado sobre la seguridad del paciente. Esa es una, o sea, es una oportunidad de llegar a todos, a todo el personal y saber qué cosas han identificado, hay una sección incluso de comentarios también, donde la gente comenta. Entonces, esto tiene dos, digamos, impactos. Primero, escucharlos, pero por otro lado, es una oportunidad también de educarlos y de llegar a todos a ellos. Simplemente llenar la encuesta, ¿cierto? Que te llegue una encuesta donde te pregunten sobre temas de seguridad del paciente, hace que todos, digamos, estén involucrados. Ese es un punto ya de por sí, así no hagas nada con la encuesta, solo lanzarla y que llegue a mucha gente tiene un impacto. El otro es que se necesita el compromiso de los líderes para hacer la encuesta. Así que también es una oportunidad para llegar a los directores, a los jefes de unidades, ¿cierto? Y poder, pues, mirar qué tan comprometidos están, ¿cierto? Y también medir cómo percibe el personal sobre el compromiso de ellos. ¿Ok? Entonces, ese es un lado, es el lado de cómo la encuesta es una oportunidad para, ¿cierto? Para saber, para mejorar, para llamar, digamos, para hacer un llamado a todo el personal. Pero el otro componente es lo que uno aprende de la encuesta. Y lo que uno aprende de la encuesta es identificar gaps, brechas. ¿Qué puntos, ¿cierto?, de las dimensiones de la seguridad del paciente son los más críticos? Puede ser falta de personal, puede ser que trabajan demasiado, puede ser que no perciben un compromiso del mando medio o un compromiso de los directores. Puede ser que hayan fallas en la comunicación entre equipos, ¿cierto? O con otras unidades. Entonces, la encuesta permite identificar dónde están los problemas que afectan la seguridad del paciente en toda la organización. Puedes también ver con la encuesta si este es un tema más de percepciones de las enfermeras y no necesariamente de los médicos. Así que la información que te da es muy rica para poder, digamos, atacar puntos específicos. Una unidad en específica, un grupo de profesionales específicos, o el reporte de errores, o la parte punitiva, ¿cierto? Entonces, obviamente la encuesta en sí misma, como dije, tiene un beneficio, pero lo más rico, digamos, lo que va a poder tener más impacto es lo que hagas con la encuesta, ¿cierto? Cómo te vas a comparar con otras organizaciones de Colombia o de la región o de Estados Unidos, ¿no? Identificar esas brechas. Y una vez que uno identifica las brechas, digamos, trabaja en equipo para encontrar planes de acción, ¿no? Y cómo mejorar esas brechas. Y si esta encuesta se hace como, digamos, se sugiere que debe ser cada 2 años, uno puede medir y ver cómo ha ido, digamos, impactando estos planes, ¿no?, de acción. Entonces, la encuesta es muy útil en ese sentido, ¿no? En el sentido de que llega a todos, y segundo, en el sentido de que puedes tomar acciones específicas, concretas y medibles, ¿no?
Muchas gracias.
Bueno, muchas gracias al profesor Alejandro. No sé si hay otra pregunta adicional.
Andrés, solo me gustaría señalar que quiero agradecer a la Universidad del Valle y quiero además invitar a otros alumnos a que participen. En esta oportunidad han sido alumnos de FIU que han colaborado con la profesora Tobar y bueno, yo te agradezco a ti también mucho, Andrés, por haber moderado el seminario de hoy y por tus preguntas. Pero invitar a la universidad, a los alumnos del Valle, pues a hacer un trabajo que vaya en las dos direcciones, ¿cierto? ¿No? También personas que estén interesadas en cómo funciona el sistema de salud en Estados Unidos y que, bueno, se puedan extender estas colaboraciones que tenemos.
Sí, perfecto. Muchas gracias, Alejandro. Y pues en estos tiempos en que Colombia está bajo una mirada a la reforma del sistema de salud, pues aprender qué funciona y qué no funciona en otros países también es muy importante. Y entonces aquí en parte hemos visto esta perspectiva de Chile y de Perú como países de la región. Entonces, pues quiero agradecer a todos los participantes y I also want to thanks to the students of you for the excellent oral presentations. We learned a lot from your presentation, and we have this discussion in both languages about the topics of the patient safety survey. Thank you very much. Muchas gracias a todos por estar aquí. Have a nice evening.
Thank you.
Thank you.
Bye
Thanks,
bye.
Jaylyn.
Thank you.
Bye.